and just want to introduce our speakers for this event. So this is Emma Drew, who is our coordinator for our Healing Arts programme, and also narrative medicine, and also I was going to say about social prescribing being your thesis topic, really, or coming within your thesis topic.
It does, yeah.
So a real expert academically and practically. And this is Jane Lodge, who's the lead for social prescribing in our CCG. So Jane has been very generous to come here today to talk to us about what's going to happen and how we're going forward with this. And I know there are many of you from other organisations, so I will leave Emma to introduce everybody else, which will go to talk first and then smaller groups. Okay, so enjoy.
Welcome, welcome, welcome. Just a bit of housekeeping. We're not expecting a fire, so in the unlikely event that there is one, you go out that way or that way. The loos are just through there in reception. Yeah, that's it, practical stuff, I think. So what we're going to do today, Jane has very kindly agreed to come from the CCG, and for those of you who don't know, the CCG is the organisation that commissions, decides on what healthcare provision we need in the city of Brighton and Hove. So very esteemed speaker. There are a number of organisations here represented that have some role in how social assets support health and wellbeing in the city. So I'm going to, after Jane has spoken, I'll ask those people to introduce themselves, and then we can perhaps have some questions. And I'm quite happy to have the organisations ask each other questions, because I think we'd all like to know how this all is going to evolve in the city. And then I'm going to give you some sticky notes. So it'll be an attack of the killer sticky notes after that. Yeah, so we've had apologies from a couple of people who would like to come but weren't able to. The Stonehouse Bakery and the Cornerstone Community Centre. So they just want to say sorry they couldn't make it, but good luck to us today. So, Jane.
Thank you. Would you like me standing, sitting?
However you're most comfortable, whatever you'd like.
Is everybody all right if I sit? Fantastic. So thank you for the introduction. As Emma and Carlie said, my name's Jane. I work at the Clinical Commissioning Group. One of the things I do is social prescribing, and I'm really passionate about it. I think we've got a number of people who are really passionate about it. So the passion in the room is all about social prescribing, which is brilliant. So before I start, have people heard about social prescribing, the term? Fantastic. No? One person that hasn't? So I find that social prescribing it's a bit of these things that when I started looking at it maybe 3 or 4 years ago, people are like, oh, what's that? They think, prescribing, is that about prescriptions, like medicine prescriptions? Because the word prescribing tends to lead you down a medical route. But I'd say since then, over the past 3 or 4 years, it's really gone up in sort of importance. And I think now it's all over everything like a bit of a rash. The NHS long-term plan, which was published, only last week it was published, crumbs, has got social prescribing in there. And for the things I read, it seems to be touted as the answer to everything, which is a little bit disturbing because it's obviously not the answer to everything. But it's really increased in importance, and now all areas are going to have a social prescribing scheme. But I think we'll find out today social prescribing will mean different things to different people in the way it's organised. So I'm going to talk about it very much from a clinical commissioning group point of view, if that's okay. I've also done a bit of research for my university course as well, because I'm really interested in the academic side of things. So again, you Google social prescribing and it's, whoa, lots of things. So basically, I mean, I've given these as a bit of an aid memoir, but I'm not going to read through them verbatim, you'll be pleased to hear. But what I've seen and what I've read, and I've got GPs in the room, which always makes me a little nervous at saying something like this, maybe 1 in 5 or 1 in 4 of the patients come through a GP's door have got some kind of social issue, which means a non-medical issue, which can't necessarily be resolved through prescribing a treatment or a drug, but they're intrinsic part of that, how that person presents to a GP. As we look through these, I've got a bit of an example. But if we're thinking 1 in 5, 1 in 4, that's quite a lot of the people that come through a GP's door. And GPs are still very much the front door to services. I mean, we saw yesterday or the day before of the discrepancies across the country with the amount of GPs and the pressure in some areas. So if people are flooding through the GP's door with lots of different problems, obviously if they are social issues, which aren't necessarily the GP's sort of bag to prescribe, really. It's taking a lot of GPs' time, and people could be supported elsewhere. And I'm not saying that the GPs begrudge this, because I'm sure you absolutely don't, but it's about getting the appropriate support for people. One thing from talking to GP colleagues in the city, you talk about the voluntary sector, and the voluntary sector in Brighton and Hove is, I think vibrant would be the word, so many organisations. And you wouldn't expect a GP to know all of those organisations, or to have time to sit and look through your little black book and to say, oh yes, carers centre, I know there's a carers centre, let me just have a look. You wouldn't expect a GP to know that. And as we know, GPs are incredibly time pressured. So this is where social prescribing can help. So it says here, it's community referral is sometimes how it's referred to, and I've known other names for it as well: wellbeing prescriptions, social prescriptions, wellbeing hubs, all kind of things. But basically, it's linking up somebody who's got a social need with the appropriate support for them that can sort out the problems. And the types of problems can be anything from, I think loneliness is a big one. People coming to primary care, not because they're lonely, but because part of the package they're lonely, if that makes sense. But it could be they've got problems with money, they're in debt. We've seen such a lot of problems come with as we roll out universal credit, and you can't divorce that kind of problem from the effect on somebody's physical health and mental health, obviously. So it's the things in people's lives that it might be housing, it might be debt, it might be problems to do with a disability, it might be problems to do with a family situation, obviously all impact on health. And when it impacts on health, where do you come? You come to the GP practice primarily. So it's trying to provide something to support the GP practice. And you'll see on the second side, under the word prescriptions, I mean, there's a list of things about exercise, healthy lifestyle, self-management, confidence building, learning, training. There's all kinds of things that somebody could be supported into. And I think that's the thing. It's not about a referral, about something to say, oh, here we are, that's the number you need to ring, go away and ring that number. It's about supporting people to access things. It's not about assuming that they'll be okay to do it on their own, but it's empowering people also to do something for themselves, because that increases people's confidence and their sense of well-being. And I think one of the things Emma said earlier was about equalising the relationship between the patients and a medical practitioner. It's about that as well, and it's seeing somebody holistically. It's not seeing somebody as, here's that person with depression, or here's that person with a problem with their legs. It's actually seeing somebody as a whole person. Does it kind of make sense? Okay. So what I've tried to do, rather than go on and on about the merits of social prescribing, I've used a bit of an example. And if you look at this page, you've got a poor old chap called Sam. Poor old Sam. He does look sad. He's got a bit of a thundercloud over him as well. So Sam is 72, and his wife died a year ago, and he's feeling lonely. His arthritis is getting worse, and he can't get out and about and do the things he used to do. He's having trouble cooking for himself. In fact, he doesn't usually bother. He's feeling very down, and everything is an effort. So, fairly realistic situation. I picked on somebody elderly, but anybody can be in this sort of situation. Loneliness is a really big thing. I know from my mum, when I lost my father, my mum was lonely. She was isolated because the social networks were for two people. So it is a big thing, and sometimes it's not about, it may not be about the amount of contact you've got, or your family around, or the amount of money you've got. You're just lonely because it's what's happening in your life. So, and we know that as people get older, their health problems get worse, and there's more of them. The older you get, the more health problems you get. I think once you hit a certain age, the average is 5 health conditions, which is a bit depressing. I'm going to buck that trend, I'm sure of it. I'm trying to be healthier. But also, this chap's having trouble cooking for himself. Now, cooking for one, especially when you're elderly, you can't get out to Tesco's like you used to do. I know from talking to elderly people that is a problem. And obviously, if people don't eat properly, I'm stating the very obvious here, if people don't eat properly, they're low in energy, that can affect their mental well-being. And so you've got a situation where you can see it all going to get a bit too much for this poor person called Sam. And the Sams of this world are probably the people that are known well to GPs, because these are the people who come in for their various appointments, arthritis appointment, lung appointment, whatever it might be. But there's a lot underlying that. When I was doing some work recently on loneliness, I was looking at an Age UK report, and there was a really brilliant quote. Somebody said, I like going down to my GPs because the receptionists are really friendly. I go in for a chat because they're lovely. And you think, well, how sad is that somebody is so lonely that their social interaction is with the GP practice? And it's not even with the medical practitioner, it's with the people on the desk, because most receptionists are lovely. You build up that rapport, you build up a relationship, but really, what can you do to support this person? So this is how social prescribing would work. So Sam went to his GP because he was tired all the time and he was feeling very down. And the GP referred him to the social prescribing link worker, Julie. So social prescribing in one of the models that we look at it's got a link worker, and that's quite crucial because that's the person that has got the time to spend with the person that's got the problems. GP's time is now very pressured, everybody knows that, and I know GPs do their best to give time to people. But here you've got somebody who can spend probably an hour with Sam, and it might be in Sam's house. Certainly our social prescribers in Brighton and Hove will meet people in community settings or their homes, wherever they feel comfortable. So we've got the lovely Julie, who Sam is referred to, and Julie spent an hour talking to Sam, and it's understanding what Sam feels and what would make a difference. And again, I know from our social prescribers in Brighton and Hove that they might get a referral from a patient and they say, I don't know, so-and-so has got problems with money, for example, debt problems. And they often say when they sit down for an hour, it's the tip of the iceberg. There's a huge amount of stuff around that debt problem. It's not just debt problems, it's a whole complex web of things, and they all interact and they all affect somebody's physical and mental health. So it's about somebody taking the time to unpick that and think, okay, what can help this person? What does this person want? Which is really important. It's got to be person-centred. What does this person want? It's all very well saying, did you know there's a bingo club down the road? And that person's saying, oh goodness, the last thing I want to do is play bingo. I've always hated bingo, which is a feeling I know very well. So it is about understanding really what's important to that person, what will help them at that point in their lives. So we've got Julie, who spent an hour with Sam to understand what he wanted. And obviously the eating is a problem. So she arranged for him to go to a local lunch club. And again, lunch club's not everybody's thing. But she arranged for him to go there. Transport is such a big problem, especially for older people or people with disabilities. It's all very well saying, it's an amazing lunch club. It's, 2 streets away. But if you can't get there, if you can't get out of the house, if you're immobile, if your mental health stops you getting out of the house, if you're too scared to, and you haven't got anybody to go with, it's a big problem. It's a huge barrier, and you don't go, and you miss that opportunity. So she arranged for somebody to give him a lift. It could be you arrange for a buddy to go. It could be something like you arrange for somebody from the lunch club to come and meet Sam at his house and tell him about it and then go. So all that would be included. So when he went to the lunch club, Sam met a couple of people he used to know, and immediately you've got social contact. Immediately that's somebody to talk to, somebody who knew him before. So that's good, and hopefully that sort of thing would be ongoing. But Julie also arranged for somebody from Age UK to see Sam, and arranged for somebody to do his shopping once a week. And again, if you've been used to going out to Tesco's on your own, it's a big problem when you suddenly can't go to Tesco's. I find that with my mum at the moment. She used to be terribly independent, used to be able to get on the bus, go to Tesco's. And now I take her, or we take her, we have to drop her at the entrance, and it's an effort for her to walk from the entrance into the shop. She's okay leaning on the trolley, but it's not long to see actually that's going to become more of a problem. So to have somebody help you with your shopping could be a main thing. Nick found out that Sam likes playing chess. Again, it's taken the trouble to get in time to know somebody. What's this person about? They like playing chess. So there's a chess thing going on there. But also there's a leaflet on healthy eating, which I've put a picture in there, that actually does exist, hence the picture. And that was something created by Age UK and our food partnerships, and that was directly in response to some work we did with older people who said exactly this. When you're on your own, you lose the knack of eating, you lose the knack of eating properly. So this leaflet was developed as a really readable leaflet to help people, ageing people, to say, okay, what's nutritious? Here's some hints and tips. So again, there's somebody to help him. And you know what it is, when you're feeling a bit down, the last thing you want to do is think about food and cooking for yourself. The package of things that will lift his spirits is obviously going to the lunch club, which will help, but the package of things will lift his spirits. You hope that he will start to eat much better, feel a bit better in himself, have a bit more energy, be less tired, be less lonely. So that's kind of how social prescribing can work. And the key bit is that link worker in the middle. It's somebody skilled who can spend the time talking through, it's not what's the matter with me, what matters to me. It's a real emphasis on that person. So then we got a very changed Sam, sitting, he's smiling now, that's good, he's sitting down under Home Sweet Home. He's got the pictures of him and his wife there. And again, it's just a picture, but it just shows it can be transformational, social prescribing. It has been transformational. I've read the case studies. We know that from our work in Brighton and Hove, but we know that nationally. So just looking at this one, it's how it links up. It's better health and wellbeing of the patients. Releases GP time spent on non-medical issues. And again, I'm not saying that our GP colleagues begrudge that time, but it's the best use of their time. And patients directed to the community support they may not have been aware of. You may not know there's a lunch club down the road. You may not know there's a exercise club that you can go to, anything like that. But the big questions that, Emma suggested to me about big questions. What are the big questions? What are the big success factors for having something like this? Part of the problem from the point of view of the clinical commissioning group, who holds the purse strings, to be blunt, is how do you demonstrate impact? How do you actually say, we spent this amount of money, and this is the amount of money we're getting back? And that is really difficult, because it's about the person. You can't put a price on somebody being less lonely. You can't put a price on somebody eating better. You can say, my common sense tells me that they'll go to the GP less because they're feeling less tired, they're feeling better, they're confident. But you can't put a price on that. It's not like saying, we will invest this amount of money in this and we know that it will save 5 times that money, so that's okay. So that is it's a big problem for us as people who are looking at commissioning this. It's how do we justify the use of the money? How do we evaluate this in a way that's systematic and robust and ticks our finance people's boxes when we know it's actually really person-centred? And another thing I think which is crucial for the success of this is the buy-in of the GPs and the practices themselves. Here you're preaching to the converted, because this practice is steeped in this kind of work. The GPs, the staff really get social prescribing, which is fantastic. It's not something you find everywhere for whatever reason. So how do you get the GP buy into this? So actually they think, oh yes, I will. I'll refer that patient to social prescribing. And what we found is unless you're constantly reminding some GP practices about this, it falls off the radar because there are so many other pressures on a GP time. So in Brighton and Hove, just very quickly, our social prescribing scheme in primary care is run through an organisation called Impetus. They're a fantastic organisation. And our link workers are called community navigators. Now that's been building up for the past, say, 3 or 4 years. We started with a small number of practices, about 16 out of, I think at the time there were about 45 practices in the city. And we've been building it up to try and roll it out in the city. So we've now got to a stage where all practices could refer in. Part of the problem is that not all practices are taking it up. It's not embedded in practices. Some practices still probably don't know. They were told maybe a year ago, but with turnover of staff, they forget it. But part of the problem is with this service, they're finding that people who are referred in, their needs are so complex, which is what I was saying. Somebody's referred in because they've got debt problems, and actually you find out there's a myriad of things that need a lot of time to unpick. And you're not just talking about one 1-hour session. You might be talking 5 sessions, 6 sessions. So actually it's quite time intensive. So what we've been finding is that the capacity that's offered has been taken up by this. And you're thinking, well, if all GP practices were all referring in, then the service at the moment wouldn't be able to cope. So we're trying to work out, what we can actually do about that. But the model is that GPs refer into a central point, Some trained staff will sort of say, okay, what's that person's need? And it's kind of a mixture between paid staff, and we've got a number of volunteer navigators who are absolutely fantastic. These are people who've typically worked in that kind of area, confident dealing with people. So that the volunteers will pick up some of the people that are signposted, and the trained staff will pick up other cohorts. It depends on sort of the need, the complexity, on what the issues are. But the principles are the same. They are a link worker. They spend the time with somebody. They are very, very well tapped into all the community support, all the things that you do probably, really well tapped in. So they're the best place to say, actually, I know of the Carers Hub, that could really help you. I know of the Disability Advice Centre, that can really help you. I know of the Money Support Service. I know about the Hot 50 Plus Club that does lots of activities for older people, mental health support. So they will know all these things. And again, you wouldn't expect a GP to know. So it's all about a supported referral onto a community organisation. Impetus, as part of their work, do a lot of following up with people. So they do actually that, how is this affecting the person? And so they'll, at the beginning, they will ask people about their well-being, and once they've been referred, after they've gone to wherever they've referred to, they will ask about their well-being. And it really shows that some people's well-being and confidence does go up. So we know it really works. So we're looking to embed this in Brighton and Hove. We're looking to make this systematic so all GPs know about it. But we're also looking now to link up with lots of social prescribing schemes across Sussex, because everybody's doing it slightly differently. So there's got to be something about sort of joint learning, so what we can learn from another service. So I think I'll stop there. Hopefully I've sort of explained as far as I can. Was that okay for everybody?
Fantastic summary. Thank you very much.
I'm quite happy if there are any questions.
Yeah, please.
Go ahead. I just wanted to go back to what you were saying about needing to prove to the finance people its effectivity and what you get back for it.
Yeah.
So I think we've got a little bit stuck maybe in saying, well, we need to prove social prescribing in terms of making the money back from reductions in hospital attendance or GP appointments or whatever. But we don't put the same requirements on our smoking cessation programs or on our hypertension programs or anything like that, even though social isolation is absolutely known and has been studied, and there are so many really well evidenced trials to say that it is as big a risk factor for all mortality. So you shouldn't need to present a case like that for it. It is a major risk factor for illness of all types. So it should be something which is just agreed that we have a prescribing budget for, and that prescribing budget is social prescribing. Yeah. So my feeling is that within sort of any organisation, we shouldn't need to prove it in that way. It is a risk factor for all types of illness, and so it should just have a budget that is allocated to it. Yeah.
I absolutely completely agree with you, and it is a difficulty. I think now that NHS England, who oversee clinical commissioning groups, now that we're going to get some kind of framework, I think the more it comes from above, you've got to do it, and here's a framework, the more it will help with securing that funding. But I totally agree with you, because when you explain it, it's such an obvious thing, isn't it? It's such a no-brainer that this would really help people. But that working in a clinical commissioning group, very sadly, that the funds are limited. We've got to make the best use of NHS money, and people look at it in a certain way. And I completely agree with you, and I do a lot of work looking nationally and saying, how can I take the evidence? How can we use the evidence? We've just evaluated the local impetus scheme through public health, and that's given us a really solid footing to say, we know that people think it's useful. We know what some of the outcomes are. Impetus themselves do a lot of evaluation, which is the kind of individual work. So I think we just need to draw that together. And I think now that's kind of happening nationally. We'll see more. But I've also seen, when you mentioned A&E and outpatients, some of the national schemes that have been going a long time are starting to evaluate in that way. And they have shown that social prescribing can be linked with a decrease in A&E attendances, which is a really big thing for us.
There was the programme in smeared Gloucester, where they showed that I think it's a massive sort of 25% decrease in hospital admissions when they had a very effective social prescribing programme, which was much more than just link workers. And I think, so that's where I guess I would possibly slightly extend the definition of social prescribing, just so that it isn't just link workers who kind of connect people. It's actually the provision of those services which help to you know, alleviate loneliness and social isolation.
Yeah, I agree. I've given you the sort of the standard NHS definition with my NHS, but yes, I totally agree with you. It's about the networking, it's about that support, it is about the services. And you know, part of the problem is you can invest a lot of money in the link worker bit, so that works perfectly. But if you're not investing money in the services, then if it's a really successful scheme, and lots of people are referring to, let's say, the befriending scheme, because you've got lots of lonely people, befriending will fall over without the additional investment. So that's part of the work we're doing, is to try and justify not just the investment in the process bit, it's about the services people are referred on to. And I think as well, if you're investing in the services, it's not just so people can channel through a GP into that service, because people come from all different places to a befriending service. It might be from the voluntary sector, it might be from a church group, it might be from anywhere. They might refer themselves. A hairdresser.
I think they had in the Gloucester, and they had people in different sort of people who stood up and said, I want to be an ambassador for this, and then, you know, if they were working in a restaurant. And the way that we sort of think about it is that there's different stages of need as well. So there's the people who you can say, oh look, there's the community, there's the cornerstone down there, and they'll go down there on their own. And then there's people you can say, well look, we'll refer you to a link worker, and they might go and see a link worker on their own. And then there's the people who just won't do anything, but can come to the practice. So there's kind of that tier of that first stage of kind of referral, which is really what we think should be within the practice, so that it's somewhere that's really familiar, so they can come to the singing group here, or the drama group, or whatever, or the dance group, and then when they've been coming here for a bit, say, you know, a course of 8 or 10 or whatever, then they might get sort of fed into a dance group that is at the cornerstone with one of the people from here or something, and it's that sort of stepping stone that happens.
And I would add to that one of the benefits of that way of working is that you get to know,
I'm used the word complexity. Some people's situations are quite complex. And the powerful thing from my perspective is actually having the time to get to know people. I mean, GPs got very short time slots for people, and something that some of the other organisations here will do, and that we do as well, is build relationships with people. And that relationship has a kind of magic to it, and is very powerful. I mean, when it comes to things like evidence, I mean, people know I say this, I'm take the view that there's loads actually of all kinds, you know, from the clinical to the, you know, and the point you made I think was very important about bringing it together so that it's actually seen as a complete body of evidence, because it comes from all different places. And one of the most important bits of evidence from my point of view is patient testimony. It's what patients say to us. And we had a conversation with somebody this morning whose immediate feedback after taking part in the session was completely moving and brilliant, and they felt motivated to then move on to the next level of engagement. So if we can do that, and as you say, it needs to be person-centred, it needs to be about what matters to somebody, not what's the matter with them, you know. So if we can genuinely work together to work around those people in a way that they find suitable to their particular situation, then we've cracked it. But I appreciate that's not easy to do. Does anyone, before we go around sort of doing introductions, does anyone else have any questions for Jane in particular? Does anybody else want to?
Would you not say there's enough evidence, at least do a pilot or something, to see what boosting the funding would do, and then measure our hospital admissions and our A&E attendances? It does seem like there's a huge body. We know that there are CCGs that have put money in and have reduced all of that.
I think, there is that national evidence. There's certainly a scheme in, I think it's Rotherham, that showed that, as well as the Gloucester scheme.
300,000 or nearly $500,000, I think they invested.
Most of that goes into the community services, doesn't it?
Yes.
So I'm Janet, by the way, I work in social prescribing as well, alongside Jane at Impetus and also in London. So I think 2/3 of the money goes into the actual services themselves,
Yeah.
which is quite unusual, isn't it?
Yes, yeah, I think so. A lot of it is the model I've described, where it goes into the link worker. And one other thing that I thought of that might be important to point out
You
is
were just saying that a third goes into the link worker and 2/3 goes
Yeah.
into the actual
Yeah.
services. Yeah.
is in a city like Brighton and Hove, when you've got a real diversity of people, it's making sure that your social prescribing service actually is responsive to the needs of lots of different people. Which it would depend on the area, but I do think that's important.
Yeah,
as
I'm
well.
going to ask us to think about priorities in a bit,
Yeah.
because that's
Yeah.
the thing.
There's just one thing because I think that spending an hour with a patient is brilliant and sort of talking to that. I think often other people get different things from patients than we do as GPs. However, although we only have a short time with a GP, we've often seen that patient over a period of like 10 years or something. So we do know them pretty well. So there is, I feel that maybe that link with the link workers, we're not making enough of the knowledge that is already known about the patient. But maybe the patient may not, volunteer, or it then takes 5 hours for someone else to kind of re-know. I don't know whether that.
Yeah, and that's the message the NHS has been putting out recently, isn't it? That people shouldn't really be repeating the same things over and over, because they're having to talk to loads of different professionals, and I can really sympathise with that at the moment.
I think that's definitely, certainly, in all the years I've been doing that, it's one of the big messages. I don't want to keep telling my story over and over again. But I think it goes back to where you've got a practice that's got stable GP and is forward-looking like this practice. It's very different sometimes from a practice that struggles to get GPs. You've got a succession of locums or single, or where it's a bit more difficult, and you can't build up that relationship for whatever reason. So I think this practice and the way it looks at things is fantastic. But there is some practice where it doesn't quite work the same.
There's something else I'd like to pick up on, just that you were saying if we can take the time away from the GP and leave them to focus on the purely medical. And I just would challenge that a little bit, because for me, I don't really have a patient that's purely medical.
Yes.
I find, if somebody comes in with shingles, then actually it's a reason to see what's going on, why they've got it right now. And for that, as GPs, we're really perfectly placed to just to be finding out what's going on. Yeah. We're really privileged to be in a position to be people when they're vulnerable and at difficult times in their life. And often in the consultation something like that will emerge, and we might be the first person to be told. And as that, I think one of the important things is going to be to strengthen the links with GPs, to really embrace social prescribing as part of the medical role, as part of the CCG's role, that that nobody else needs to be funding it, because actually it really is part of health and wellbeing as a whole, and that all of that embraces all of us, mind, body and spirit, and it's not, there isn't a purely medical patient.
Yeah. And trust is really important. Yeah.
I certainly didn't mean that you would just focus on somebody with medical symptoms, because I know that GPs don't, and you're right, it is that first point of contact about recognising somebody has got other needs. But I suppose it's you'd been the first step of that, and identifying that, supporting the patient to be able to get to
definitely,
the next steps. Definitely
come and do that.
But I'm certainly not
saying is that it's much more than it's not 1 in 5 patients that's got social needs contributing into their illness. It's every patient that has kind of other things which are contributing and perpetuating or causing.
Yeah, and for the people who don't have their nose in the research evidence trough like me, the technical term for this is the social determinants of health. So we all know that our health is affected by where we live, by our family relationships, by our income, by our level of education, and there's masses of evidence around that.
When you do the CBD, the Q risk, one of the biggest things about is your postcode. And that's a sort of medical thing that we use all the time. So it's definitely there, and I think GPs generally are really aware of that. They just don't know what to do.
And you need a resource, don't you?
And that you need to take that step and just make sure that that your whole practice like this is kind of steeped in that, so that it is in your head all the time, and you are thinking about it.
I'm aware that we've got lots of interesting brains in the room, including our very special and pioneering GPs. I'm glad you've noticed. So should we go around the room and say who we are? We're all equal here. This is a social prescribing session. And then